Welcome to RAA Online. Today we have a very important topic, an exam topic, cerebral autoregulation. Okay. So cerebral autoregulation, this question is being asked in DNB Emergency Medicine year 2018 June final exam, paper 1, question 1B. Okay. So this can be asked as a 10-mark question or as a 5-mark question or any specific segments as 3-mark question as well. Okay. And in real-time Viva, you will be asked about cerebral autoregulation if at all your case is an ischemic stroke or a hemorrhagic stroke or an RTA or anything that is related to intracerebral pressure, you might be asked about this. Okay. So let's go into cerebral autoregulation. On the first place, what do you mean by cerebral autoregulation? Okay. It is the ability of the cerebral vasculature to maintain a stable blood flow, whether the patient have hypotension or the patient have a hypertension, the cerebral blood flow need to be very stable. Okay. So that ability of the cerebral vasculature is called as cerebral autoregulation. Okay. Whether the blood pressure falls, whether the systemic blood pressure falls or the systemic blood pressure rises very fast, still the particular cerebrum has to receive proper stable blood supply. Okay. So this ability is called as cerebral autoregulation. Okay. So can you see this image? So here for a mean arterial pressure, okay, remember MAP of 50 to 150. Okay. So between a mean arterial pressure of 50 to 150, this usual autoregulatory mechanism will be active. Okay. But in some situations, because of a trauma, because of an ICH, because of maybe an meningitis and infection, this autoregulatory mechanism may be insulted. Okay. So a patient, if at all they have a mean arterial pressure less than 50, the brain tissue can go for ischemia because of impaired dilatation and arterial collapse. If the mean arterial pressure, okay, MAP, if the mean arterial pressure is more than 150, so there will be forced dilatation of the vessel causing vasogenic edema, right? So blood pressure has to maintain between a mean arterial pressure of 50 to mean arterial pressure of 150 relatively, so that the brain is saved if at all the autoregulatory mechanism is intact. Okay. So I have given you two different points now. Number one, if the autoregulatory mechanism is intact, then a map of 50 to 150 is relatively stable for the brain, right? Meaning less than 50 or more than 150, even for you and me, it's going to be very difficult for the brain, right? Second, in any situation, if this autoregulatory mechanism itself is insulted, so this 50 to 150 is not going to be the guideline number, right? You need to document what is the perfect blood pressure for that particular gentleman, right? Maybe you need to measure the cerebral perfusion pressure, intracranial pressure, and then come to a conclusion, right? So in exam, if they ask you what is cerebral autoregulation, it is the ability of the cerebral vasculature to maintain a stable blood flow despite changes in the blood pressure. Okay. So in normal people, cerebral autoregulation happens between the mean arterial pressure of 50 to mean arterial pressure of 150. Below 50 of MAP, there could be ischemia. Above 150 of MAP, there could be vasogenic edema in otherwise normal individuals. Okay. This is called as autoregulation, and which has some mechanisms which we will see it in detail. Okay. So under otherwise normal circumstances, cerebral blood flow is regulated through changes in the arterial diameter, which I just said you know. Okay. So based upon the diameter change, the resistance also changes, right? The more is the diameter, the easy is going to be the flow, right? So easy flow meaning less resistance. When the diameter is very less, resistance is going to be very high and the flow is going to decrease, right? You got the concept? For example, the patient is having a sudden high blood pressure, okay? Lot volume of blood is coming towards the brain, right? So what the cerebral vasculature does, it just constricts. So when it constricts, this amount of pressure, this amount of blood will not reach the cerebral circulation. So the brain is protected, right? Similarly, when the blood flow is minimal or there is hypotension, this vasculature, the cerebral vasculature, the cerebral arteriolar vasculature will dilate. So the resistance is less, the flow will be better increased. So the brain will not suffer this hypotensive insult. Okay. So this flow and pressure relationship in possibly a pipe-like structure is maintained and explained by Hagen-Poiseuille equation. Okay. Hope you know what is Hagen-Poiseuille equation, right? So this describes the relationship between the pressure drop or pressure change you can take and the flow rate and other surrogative parameters, especially like in a fluid flowing through a pipe. Here the fluid meaning the blood and the pipe meaning the blood vessels. Okay. So this is a fundamental equation of any fluid dynamics, not only the brain, not only the blood and the vasculature, for any dynamics regarding a cylindrical pipes. Okay. Let's discuss one word about Hagen-Poiseuille equation. Okay. So the delta pressure is equal to 8 into eta into L into Q divided by pi R power 4. Okay. So this is the equation, Hagen-Poiseuille equation, where the delta P is the pressure difference and eta is the dynamic viscosity of the fluid. L is the length of the pipe. For example, in case of transcranial Doppler, when you decide, you'll be able to decide the length of the pipe which you are measuring, right? And similarly, Q is the volumetric flow rate and R is the radius of the pipe. Okay. Let us not go deep into the Hagen-Poiseuille equation, okay, because you will not be using this in the real-time practice, right? But in your question, if at all it's going to be a 10-mark question, if they ask about this Hagen-Poiseuille equation, you need to write this along with these points. Okay. So now you have the brain structure, all right, and there is vasculatures. There is vasculature. So based upon the pressure difference, the vasculature are going to change their diameter so that a stable blood supply is maintained in the brain, right, depending upon the blood pressure. Okay, this is called as auto regulation. This is what we are going to read now. This is what we are going to discuss now. Okay, similarly, there are other things which can influence the diameter of that particular vessel. So those are carbon dioxide reactivity, flow metabolism reactivity. Okay, carbon dioxide reactivity is different, flow metabolism reactivity is different, cerebral auto regulation for the blood pressure is different. Okay, so the carbon dioxide relativity and the flow metabolism coupling has nothing to do with systolic blood pressure. Okay, has nothing to do with the pressure mechanism. So these three are three different phenomena that can increase or decrease a particular vasculature, which can increase or decrease a particular blood supply in the brain. Okay, so possibly, dear emergency physicians, you would have intubated a patient and possibly the patient is having an edema in the brain or there is a bleed in the brain. You feel the ICP is on the higher side, patient might have a midline shift. So what usually we will set the ventilator for? You will set the ventilator to decrease the CO2, right? Ultimately, you will not allow a CO2 to build up, right? At least you will maintain a eucarbia 35 to 45. Why do you maintain a eucarbia, right? So why, if it's like CO2 is like 50 or 55, what wrong in that, right? The point is, if there is a cerebral edema and you are maintaining a higher PCO2 will cause a dilatation of the cerebral vessels. So when the cerebral vessels dilate, already it's a very closed cavity. The brain, the cerebrum, the calvaria, the skull box is basically a closed cavity, right? Already it's a closed structure with increase in pressure. If you increase the carbon dioxide, it increases the vessel diameter, which adds to the pressure. It is for that reason, in any case, if you feel the ICP is on the higher side, the pressure inside the cranial box is on the higher side, then you need to decrease the PCO2. Okay, point number one, do not allow a higher PCO2, or in an emergency situation, in a dire emergency situation, you can bring down the PCO2 to even 30. Okay, so lower the PCO2, lower is the diameter of the vessels, smaller is the diameter of the vessels, so the pressure is expected to come down a bit. Okay, so higher the PCO2, more will be the dilatation of the vessels, more will be the pressure inside the brain, right? So this one phenomena you are using it on a daily basis, right? So this is called as carbon dioxide reactivity. Okay, please understand, we are speaking about systemic carbon dioxide. Okay, you take an ABG, the CO2 will be high. That's what we are speaking about. There's other thing called as localized carbon dioxide. What is localized carbon dioxide? Basically, now what if I ask you what is my potassium value? You'll specifically take a sample and you'll check and you'll say this is the potassium value. You'll specifically take and you'll check, you'll tell me what is the PO2 and SO2. So now I'm giving you a scenario, right? One of my index finger is completely gangrenous. If you check the oxygen saturation, what will be the oxygen saturation in this particular limb? This particular finger, which is gangrenous, will show a low O2, right? But my systemic blood supply will have a higher O2. So what I'm trying to tell is there are two different O2s, there are two different CO2s. One is systemic, that is which is going through the blood supply, going through the arterial supply. This is systemic PCO2, systemic O2. And the other thing is localized to particular area. Okay, if there is a particular ischemia, that particular tissue will go for anaerobic respiration. So because of anaerobic respiration, CO2 will build up, oxygen will go down in that particular vessel, in that particular segment of the vessel, in the particular distribution area of that particular vessel. You got it? So here, what we are speaking about, carbon dioxide reactivity means I am telling about systemic carbon dioxide, right? The patient is not able to breathe well, there is a CO2 getting stuck. So this CO2 can go into the brain, which can cause dilatation, which increases the pressure. If you intubate the patient, or for some mechanism, the patient is breathing very fast and CO2 comes down in a systemically, that is all through the body, then that can reach the brain as well, and the particular vasculature can come down. Okay, this is systemic carbon dioxide reactivity. You can even use the word systemic carbon dioxide reactivity. And the second thing is flow metabolism coupling. What is that flow metabolism coupling? For example, particular segment of the brain is responsible for particular functioning, right? For example, you think about a particular skill, or you do a mathematical equation, you solve a mathematical equation, you get trained in mathematical equation, or you get trained in a particular bicycle, or you particularly train in painting. So these are particular centers in the brain. So when you use particular centers in the brain, the demand of oxygen, the demand of blood supply to that part of the brain is high. You get my point, right? So for example, if I use a dumbbells very fast, if I go to gym, if I use a dumbbells very fast, this particular muscle will demand more amount of blood supply, right? Similarly, even in the brain, if at all you try to trigger particular brain area by doing a mathematical equation, or you cycle, or you paint, or use your thumb finger, whatever it is, if you trigger or activate a particular segment of the brain, that particular segment of the brain will demand more oxygen, more blood supply, and more metabolic clearance. Okay, that is called as a flow metabolism coupling, right? So what all can increase or decrease the diameter of the cerebral vasculatures? One is your pressure based autoregulatory mechanism, which we are going to see now. The other things are systemic carbon dioxide reactivity. Third is flow metabolism coupling. Okay, these are the three major factors which can increase or decrease the blood flow to a particular segment in the brain. Okay, so today's topic we are going to discuss about cerebral autoregulation, but you need to know there are other two aspects like carbon dioxide reactivity and flow metabolism coupling, which has nothing to do with pressure, okay, but still can increase or decrease the blood pressure, cerebral vasculature pressure. So carbon dioxide reactivity. Systemic carbon dioxide reactivity describes vascular reactions in response to changes in the partial pressure of arterial carbon dioxide, but does not consider reaction to pressure changes. Similarly, a flow metabolism coupling means regulating cerebral blood flow relative to the local cellular demand. For example, as a consequence, you are doing a neural activation during cognitive tasks, you are painting, or you are doing a particular skill set, then particular area of the brain will demand more amount of blood supply and oxygen supply, right? So this is called as flow metabolism coupling. This is also irrespective of fluctuations in cerebral perfusion pressure. Okay, this is pressure independent mechanisms. Okay, so flow metabolism and CO2 reactivity are pressure independent mechanisms. Autoregulation is pressure dependent mechanism. Let us go to the cerebral blood flow regulation physiology. Let us look at the mechanism, how it's done. So cerebral oxygen delivery is a function of the blood flow. Okay, not only the blood has to flow, not only that, the blood has to carry oxygen, right? So the cerebral blood oxygen delivery is a function of blood flow and blood oxygen content, right? So this particular cerebral blood flow is dependent on the forward pressure and the resistance. The forward pressure is a cerebral perfusion pressure. Okay, what do you mean by cerebral perfusion pressure? So there is one, consider this to be the brain. There is a pressure which takes the blood into the brain, right? There is a pressure which is against it. So ultimately, what determines the flow inside the brain is the summation of these two, the difference between these two. So what is the pressure that takes the blood to the brain? This is called MAP. What is MAP? Mean arterial pressure, right? For example, say the mean arterial pressure is 80. And the total ICP, this is intracranial pressure, the total pressure in the brain against which the MAP need to take the blood. Okay, intracranial pressure is a pressure from the brain substance, right, inside the calvaria, okay, inside the skull. So, for example, the intracranial pressure is say somewhere around 15. So, what is the cerebral perfusion pressure? CPP is nothing but MAP minus ICP, okay, is equal to 80 minus 15 is equal to 65. Okay, 65 will be the cerebral perfusion pressure. Okay, so mean arterial pressure takes the blood towards the brain, and ICP or the intracranial pressure stops it or gives resistance towards it, right? So MAP minus ICP gives you the CPP. Okay, so the cerebral blood flow is dependent on the cerebral perfusion pressure. Okay, and second thing is any forward flow is inversely proportional to the resistance of the pipe. Okay, I have a very small pipe here, and I'm going to send a lot of blood through it. I'm going to send a lot of blood through it. Imagine if this particular vessel is stiff, then this amount of blood cannot go through it, right? The stiffness of that particular vessel, otherwise known as resistance. The stiffness of that particular vessel, otherwise known as resistance. Okay, it can be a stiffness of the vessel or some external compression towards the vessel, whatever it is. Okay, so the flow is indirectly or inversely. The flow is inversely proportional to the resistance. Okay, so let's understand this. The blood flow to the brain is via a pressure gradient. Okay, the entire circulatory system in your body itself is a pressure gradient mechanism. The blood flows from the higher pressure towards the lower pressure, right? So from the left ventricle with the pressure of 120, the systolic BP shoots, right, and it gets carried towards the body, and ultimately during right atrial diastole, in right atrial diastole, it is going to be in a negative pressure, right? So from a positive pressure, it circulates and goes towards a negative pressure. So any movement of fluid is basically based upon this pressure gradient. Okay. So similarly in the brain as well, the blood flow to the brain is via the pressure gradient between the supplying arteries, as the MAP, and the venous system. You can use the word as venous system, or you can use the word as ICP. Okay. Basically, if at all there is a brain material, if there is any other compression things inside like arterial leak or hematoma or SAH, these are all going to press on the venous system, right? Ultimately, the venous pressure is going to be high. So intracerebral pressure can be equated to central venous system pressure. Okay. So now coming to the cerebral blood flow. So as I told you, if the cerebral perfusion pressure is high, blood is going to go better, right? So that is directly proportional, right? If the stiffness of the vessel is very high, the resistance is very high, the cerebral blood flow is going to come down. So they are inversely proportional. Are you getting what I'm saying? So cerebral, for example, MAP, MAP, MAP minus ICP. This is going to be a CPP, right? So MAP is the pressure with which the blood is coming towards the brain. MAP mean arterial pressure. Okay. ICP is what is seen inside the brain material, inside the skull material, right? Basically. So difference between these two is the cerebral perfusion pressure. So more is the pressure, more is going to be the blood that is reaching the brain. So they are directly proportional. Imagine that particular vessel is very stiff, then the resistance is very high. So the amount of blood going to reach the brain is going to be very less. So this will be more resistant, less blood flow. So they are indirectly proportional, inversely proportional. So CBF is equal to CPP by CVR. Okay. So let's substitute. You get this. So MAP minus ICP by CVR. So this is the formula for cerebral blood flow. Okay. You need to write this in exam as well. So mention these four mechanisms, that is myogenic theory, neurogenic, endothelial and metabolic process. Okay, these are the things which regulate the cerebral auto-regulatory mechanism. So number one is the myogenic tone. So myogenic tone is produced when the arteriole or small artery smooth muscles contract in response to increased pressure. Okay, so imagine this is the cerebral blood vessel. Okay, suddenly too much of blood is coming inside. Too much of blood is coming inside. Okay, this is the brain. So what is the nature supposed to do? Nature supposed to constrict this particular blood vessel. This volume of blood doesn't reaches the brain. Okay, if such a high volume of blood reaches the brain, it will cause vasogenic edema. It may even leak, it may even bleed, right? So to stop this kind of heavy or higher volume of blood coming towards the brain, if the pressure is increased, the arteriole diameter decreases. Okay, that is done by the myogenic tone. In contrast, if the volume of blood is very less, okay, only very little blood is coming towards the brain, What is that nature supposed to do? It just dilates the vessels. Once you dilate the vessel, the resistance comes down, more amount of blood flows. Okay, this is how the myogenic tone, the smooth muscle tone, saves the brain from hypotensive episodes and hypertensive episodes, somewhere between 50 to 150 mmHg of systolic blood pressure. Got it? So, myogenic tone is produced when arterioles or small artery smooth muscle cells contract in response to increased pressure, okay, and relax in response to decreased pressure. Okay, so this kind of transmural changes activate mechanical sensitive ion channels and proteins in the vessel wall, triggering this kind of changes in the vascular diameter. So, whenever you speak about a smooth muscle, you're going to speak about depolarization, calcium ions, the light chain kinases, myosin, actin-myosin interactions, all these things. So, this is basic physiology. Okay, I'll just put a word about what this basic physiology is, how a smooth muscles contract and relaxes, right? For instance, membrane depolarization opens the voltage-gated calcium channels, leading to influx of calcium into the muscles, smooth muscle cells. So, this calcium activates myosin light chain kinase, okay, which activates the myosin by phosphorylation. So, ultimately calcium has activated the myosin. Okay. Once calcium has activated the myosin through this kinase, this phosphorylated MLCK increases the actin-myosin interaction. Okay. From there it goes here. So, calcium activates the myosin with MLCK. Then with the phosphorylated MLCK, myosin binds with actin and causes actin-myosin interaction. So, calcium, myosin, actin-myosin interaction. Okay. This causes cell contraction and vasoconstriction. So, why are we dealing with it? So, remember there you will see some patients who comes with the recurrent stroke, right? There are a lot of reasons for recurrent ischemic stroke, and one among them is Cadasil. Okay, what is that? Smooth muscle cell myogenic regulation is important in cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. This is called as Cadasil. Okay, cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. This is called as Cadasil. Okay, so I told you that there is smooth muscles. When the blood pressure is very high, they need to contract. When the blood supply or the blood pressure is very low, they need to dilate. Okay, this mechanism preserves the brain, prevents the brain from hypo and hypertensive episodes. If this particular mechanism of myogenic contraction relaxation is lost or not there genetically, then that particular brain substance is more prone for ischemic events and vasogenic events, more prone for basically ischemic events, right? So, they come with multiple ischemic conditions again and again and again repeatedly, right? So, patients with Cadasil show a degree of smooth muscle cell degeneration in small cerebral arteries. So, studies have demonstrated impaired myogenic autoregulatory functioning in animal models and individuals with this genetic condition. Okay, this occurs basically because of mutation of Notch3 gene. Okay, and this is how the patient presents with recurrent ischemic strokes, cognitive impairment, subcortical dementia, mood depressions, disable like depression, apathy. Understand, not all stroke comes with weakness of one side of the body. Understand that. Okay, it's not that much the patient should come with a weakness of left side or aphasia or loss of consciousness. Not necessary. Okay, maybe a hiccups. Okay, hiccups will be the only sign of brainstem infarct. Right? Visual loss can be a sign of infarct. Right? Cognitive impairment can be a sign of infarct. Right? So, a lot of ways the patient can present. Right? If there's a recurrent ischemic infarct, that could be because of deletion or an issue with the Notch3 gene. Okay, which is responsible for the myogenic mechanism of autoregulation in cerebral vasculature.